Everyone for joining. Thanks everyone for joining the MAPP rounds today. I have the pleasure of introducing our speaker, Dr. Jenny Rabin. Dr. Jenny Rabin is a clinical psychologist and assistant professor at the Sunnybrook Research Institute and the University of Toronto. She received her PhD in clinical psychology from York University in Toronto, and then went on to complete her internship and postdoctoral research fellowship at MGH and Harvard, and many of you may know her from her time here. She currently is researching using both neuropsychological testing and neuroimaging to better understand modifiable risk factors for Alzheimer's disease and related dementias. And today she'll be talking with us about the vascular contributions to Alzheimer's disease. Thanks, Jenny, for being here today.
Thank you. Thank you for the nice introduction. And it's great to be back and to be speaking to all of you about vascular contributions to Alzheimer's disease. So I'm just going to take a minute to pull up my slides. All right, does that look okay?
Yes.
Okay, thanks, Yakao. Okay. So as we all know, Alzheimer's disease is defined by the presence of amyloid plaques and neurofibrillary tangles. And you can see that here in the brain of a patient who died of Alzheimer's disease. So the orange circles here are the plaques that deposit between the neurons, and the black stringy things that you see here are the tau tangles that deposit within the neurons. And we now know that these plaques and tangles begin to form in the brain at least 15 to 20 years before an individual presents with clinical symptoms. So down here in the corner, this is what we recognize as Alzheimer's disease dementia, when a person presents with cognitive difficulties and can no longer carry out activities of daily living. And this is the stage of the disease where many clinical trials have failed. And one possible reason for this is that at this stage of the disease, there's already been years of irreversible brain damage. So approximately 20 or so years ago, researchers started focusing on an earlier phase of the disease known as mild cognitive impairment, or MCI. And we know that MCI is a significant risk factor for progression to dementia. However, even clinical trials occurring at this stage of the disease have yielded disappointing results. And this is likely because even by this stage of the disease, there's already significant neuronal loss. And so we need to go back even further and focus on this preclinical or asymptomatic phase of the disease. And the idea here is to stop or to slow the disease before widespread damage occurs. And so we need to identify the individuals who are on this Alzheimer's trajectory from those who are on this successful aging trajectory. And so over the last 2 decades or so, the field has developed biomarkers that now allow researchers to estimate amyloid burden in the brain. And we can do this in 2 ways. 1, by analyzing cerebrospinal fluid from a lumbar puncture, and 2, by analyzing amyloid PET data. So here I'm showing amyloid PET data, and the images on the far left are a healthy control. And the image on the far right is an Alzheimer's disease dementia patient. And the warm colors here denote elevated levels of amyloid in the brain. Now, the middle image here is a clinically normal older adult with elevated amyloid. And so this is what we call preclinical Alzheimer's disease, when you have elevated amyloid in your brain, and yet you are cognitively normal, so have no memory problems. And we know from both postmortem data and now amyloid PET studies that about 30% of clinically normal individuals over the age of 70 have elevated amyloid deposition in the brain. So if we examine the cognitive performance of these amyloid positive individuals over time, we can see that they decline. And that's what I'm showing here. So this is data from the Harvard Aging Brain Study, an ongoing longitudinal study of healthy aging and preclinical Alzheimer's disease. So here on the x-axis, I have time, and on the y-axis, I have memory performance. Can you all see my cursor okay?
Yes.
Okay. And so I have the amyloid positive individuals in red and the amyloid negative individuals in blue. And you can see that both groups start off as clinically normal with a Z-score or Z-score of 0. But then you can see over time that the amyloid positive group declines, whereas in contrast, the amyloid negative group gets better. And we think that this is reflecting a practice effect. So if you give the same test to healthy people year after year, they're likely going to get better on those tests. So now I'm showing you the same data, but I've divided the group into amyloid negative and amyloid positive groups. I again have time on the x-axis and the memory composite on the y-axis. And these lines here look a little bit less steep because I've extended the range. So what I want to show you is what's underlying these really clean group means. And that's the messy reality of the individual data points. So each line here represents a single participant's cognitive trajectory, and then the length of the line represents how long that person has been followed over time in the study. And I think what you'll immediately appreciate is just how much variability there is in this sample. But focusing on this amyloid positive group, you can see that as a whole, the group declines over time. However, there's actually some individuals whose performance remains stable, and even some individuals whose performance gets better over time. And so this is really the crux of what I want to understand is why are some people more susceptible to the effects of amyloid than others? Or to flip this around, what are the factors that might protect someone against amyloid-related cognitive decline? So we've known for a long time that vascular burden is associated with cognitive decline and progression to dementia. So this includes vascular pathology such as atherosclerosis and white matter hyperintensities, as well as vascular risk factors such as hypertension, obesity, and diabetes. So we also know that when individuals present with both vascular pathology and Alzheimer's pathology, they're more likely to show faster rates of cognitive decline. So these are autopsy data from the Rush group. And in this study, the authors looked at how frequently different pathologies occur together across individuals with normal functioning, mild cognitive impairment, and probable Alzheimer's disease. And what the authors found is that Alzheimer's and vascular pathologies commonly co-occur. So you can see that here in the turquoise and the navy pieces of the pie. So 33% of people with no cognitive symptoms had both vascular and Alzheimer's pathology. 48% of people with MCI, so almost half, had both pathologies, and almost 75% of people with Alzheimer's disease dementia had both pathologies. And I think it's really interesting to note that pure Alzheimer's disease is actually quite rare, particularly at the symptomatic stages of the disease. So you can see that here at the stage of MCI and even smaller at the stage of probable Alzheimer's disease. Now, the fact that vascular pathology mixed with Alzheimer's pathology is so common, particularly at these symptomatic stages, really made me wonder whether these pathologies are interacting in some way to accelerate cognitive decline and progression to dementia. And so this is what I set out to test over a series of studies. And specifically, I was interested in testing whether vascular burden and amyloid have independent or interactive effects on cognitive decline. And I hypothesized that vascular risk and amyloid would interact to accelerate cognitive decline, and that this would occur through two mechanisms, through tau deposition and brain atrophy. And so this is the story that I'm going to tell you today. And hopefully I can convince you that vascular burden drives cognitive impairment in part through Alzheimer's disease pathways. And I think this is a really exciting story to tell because we know how to treat vascular burden. So in terms of the data that I'm going to show you today, most of the data I will present are from the Harvard Aging Brain Study. So as I mentioned earlier, it's a longitudinal observational study that includes more than 280 individuals. At baseline, all participants were clinically normal and between the ages of 60 and 80. And I wanted to just highlight some of the exclusionary criteria that I think are important to keep in mind as I go through and discuss our different study findings. So we excluded people who have a stroke or major vascular event. We excluded people with extensive white matter changes and also people who have unstable hypertension and diabetes. And so if you think about these exclusionary criteria, we're essentially excluding people who potentially have the highest level of vascular risk. So when you interpret our study findings, just remember that we're really at the bottom to middle level of vascular risk. So the first question we set out to ask or to answer is, does vascular risk and amyloid have interactive or independent associations with cognitive decline? So we quantified vascular risk at baseline using the office-based Framingham Heart Study cardiovascular disease risk score. So this score is a weighted sum that takes into account a number of risk variables that I've listed here. And it predicts the likelihood that an individual will sustain a cardiovascular event in the next 10 years. And the benefit of using a multivariable score like this one is that it allows for multiple risk factors to be examined simultaneously, which is really important because we know that vascular risk factors tend to co-occur and increase the likelihood of a cardiovascular event. So cognition was assessed with the preclinical Alzheimer cognitive composite, or the PAC. So this is a cognitive composite that's weighted heavily towards episodic memory and is being used increasingly in preclinical Alzheimer's work. And the reason for this is that this composite has been shown to be particularly sensitive to amyloid-related cognitive decline. So amyloid in HABs was measured with PET using Pittsburgh compound B, and we looked at uptake across frontal, lateral, parietal, and temporal, and retrosplenial cortices. So we call them the FLR regions. So before delving into the main findings of this study, I just wanted to show the distribution of vascular risk scores. So on average, participants had about a 33% chance of sustaining a cardiovascular event in the next 10 years, and scores range from about 3% up to 83%. And then at baseline, we found no association between amyloid burden and vascular risk. So you can see that this line is pretty flat. And this finding is consistent with some studies, but other studies have found an association between these two variables. And so in HABs, all participants are required to be clinically normal at baseline. So this means that individuals who have both high amyloid burden and high vascular risk are likely not well represented in this study, since these individuals are much more likely to be cognitively impaired and therefore not eligible for HABs, since you have to be cognitively normal at baseline. So it's possible that this might explain some of the discrepancies across the different studies. So in terms of the main findings, we found a significant interaction between vascular risk and amyloid on cognitive decline, whereby higher vascular risk and higher amyloid burden was associated with faster cognitive decline. So to show the interaction, I've divided the sample into lower amyloid burden and then higher amyloid burden, and then plotted the effect of vascular risk. But I just want to point out that amyloid was used as a continuous variable in our analyses, and I've just dichotomized it for illustration purposes. So this red line indicates higher vascular risk and the blue line indicates lower vascular risk. And so across both groups, you can see that higher vascular risk, shown in red, was associated with faster cognitive decline, but that the effect is much larger in the high amyloid group, which of course is consistent with the interaction effect. Now, focusing on this high amyloid group, you can see that there is a rapid rate of cognitive decline in the high amyloid, high vascular risk group, where there's almost no decline in the group that has high amyloid but lower vascular risk. And I think these findings suggest that in the presence of amyloid, vascular risk factors can accelerate cognitive decline and substantially shorten that asymptomatic phase of the disease. And then I also want to remind you that we excluded study participants who sustained vascular events and had extensive white matter changes. So this really leaves open the possibility that these effects might be of even greater consequence in people who have higher vascular risk. So although our focus was really on this aggregate measure of vascular risk, in follow-up analyses, we wanted to examine the association between the individual components of the Framingham score and cognitive decline. So we were really interested to see whether any one of those vascular risk factors was driving the association with cognitive decline. So we ran separate models with each vascular risk factor as a predictor of cognitive decline. And here I'm showing you a forest plot, which depicts the standardized estimates along with the confidence intervals. So if the confidence intervals don't cross 0, it indicates that the effect is significant. So you can see that here that each vascular risk factor included in the Framingham score was significantly associated with cognitive decline. And so that suggests that the presence of any one of these risk factors can have deleterious effects on cognition. So I showed you evidence that vascular risk interacts with amyloid to promote cognitive decline. And so we wondered whether this is occurring through Alzheimer's pathways, and specifically whether tau burden may be involved, given that tau correlates very tightly with cognitive impairment. And so that's what we looked at in this next study. So in this study, we focused on tau PET signal as measured by fluorotaucipir in 2 pre-specified ROIs. So we focused on the entorhinal cortex because it's among the first regions to develop tau pathology with increasing age. And we also focused on the inferior temporal cortex, or the ITC, because it's an early neocortical site of tau deposition that's associated with AD clinical symptoms. And as expected, we found a significant interaction between vascular risk and amyloid burden on tau PET signal in the inferior temporal cortex. So that region that's associated with AD clinical symptoms. So on the x-axis here, I have the Framingham score, and the y-axis, I have tau PET signal in the inferior temporal cortex. And then for visualization purposes, I'm representing low amyloid burden and high amyloid burden as the 25th and 75th percentiles. And so what you can see here is that for this low amyloid group shown in blue, with increasing vascular risk, tau PET signal in the inferior temporal cortex remains relatively stable. But for this high amyloid group, as vascular risk increases, so does tau PET signal in the inferior temporal cortex. And so this finding indicates that vascular risk factors can accelerate amyloid-related tau in this region. Again, a region that tracks very closely with clinical symptoms. So here is the effect for the entorhinal cortex. And you can see that vascular risk and amyloid burden do not significantly predict tau in this region, although it's certainly trending in the same direction. And so the next thing we wanted to do in this study was, like we did the last time, was to examine whether any of the components of the Framingham score were driving the interaction with amyloid in relation to inferior temporal tau. And so again, we decompose the Framingham score into its constituent components. We interacted each one with amyloid to predict tau PET signal in the inferior temporal cortex, and that was all done in separate models. And so as you can see here on this forest plot, there is a significant interaction between amyloid and each of the components in relation to inferior temporal tau, with the exception of diabetes. And this is likely because there were very few participants in our study who had diabetes. So this is likely a power issue, and it will be interesting to see whether this finding emerges as significant in larger sample sizes that includes more patients with diabetes or more participants with diabetes. And so these findings suggest that the interaction is being driven by a number of vascular risk factors, and that each of these risk factors on their own have the potential to increase tau deposition. And just to say this another way, this means that managing any one of these vascular risk factors has the potential to slow neocortical tau accumulation in a region known to be associated with cognitive and clinical symptoms. So the last thing that we wanted to do in this study was to perform an exploratory regional analysis, just to examine whether the interaction between vascular risk and amyloid extends to regions beyond the inferior temporal cortex. And so you can see here that combined higher amyloid and higher vascular risk was not only associated with tau in the inferior temporal cortex, but also showed elevated tau in bilateral parahippocampal cortices, medial parietal regions, and also lateral temporal regions. So regions typically associated with Alzheimer's disease. So I showed you evidence that vascular risk interacts with amyloid to promote tau deposition. And so in the next study, we wanted to examine whether vascular risk and amyloid also interact to accelerate brain atrophy. Again, brain atrophy is another biomarker that tracks very closely with cognition. And so in this study, brain atrophy was quantified longitudinally with structural MRI, and we followed participants over a median of about 4.5 years. And all participants had at least 2 scans, and some participants had up to 5 scans. So as expected, in this study, we found a synergistic association between vascular risk and amyloid on brain atrophy. So the interaction was associated with atrophy in frontal regions, as you can see here, and then also anterior temporal regions, and specifically the temporal pool. It was also associated with subcortical regions, which I'm not showing here, such as the thalamus and the striatum. And so when we initially saw these results, we were somewhat surprised that the set of brain regions associated with the interaction didn't overlap with that canonical pattern of AD neurodegeneration that we typically see, which occurs in temporoparietal regions. And so these findings suggest that then heightened vascular risk does not just merely accelerate amyloid-related atrophy in Alzheimer's vulnerable regions, but instead speeds up tissue loss within the frontal lobe. So maybe enhancing a more global picture of atrophy. And then in secondary analyses, we wanted to adjust for markers of white matter injury. So things like white matter hyperintensities and also diffusion metrics to get at white matter integrity. And what we found is that vascular risk remained a significant predictor of atrophy in these regions after accounting for those white matter markers. So this suggests that the effects of vascular risk on gray matter atrophy are just not merely consequences of the white matter changes. And so the next thing we wanted to do was to see whether brain atrophy mediates the effect of vascular risk on amyloid-related cognitive decline. So is this brain atrophy that we see that's related to the interaction actually driving cognitive decline in these participants? And so we ran 2 mediation models, one at a high level of amyloid and the other at a low level of amyloid. And this was really to get at the interactive effect of amyloid and vascular risk on cognition. And so here I'm showing you the mediation model at higher levels of amyloid. And you can see here that gray matter atrophy mediated the effect of vascular risk on cognitive decline, confirming that one way by which vascular risk and amyloid lead to cognitive impairment is through gray matter tissue loss. Now, this was not the case at lower levels of amyloid, and you can see that here by this non-significant line. And so we also found a direct effect of vascular risk on cognition, both at high levels of amyloid and also at low levels of amyloid, suggesting that the detrimental effects of vascular risk on cognitive decline are not fully captured by gray matter atrophy. And so possible alternative mechanisms include things like hypoperfusion, inflammation, and breakdown of the blood-brain barrier, among others. And just to highlight this result here, that we're seeing an impact of vascular risk directly on cognitive decline, this is consistent with prior findings, and we would expect that vascular risk factors would impact cognition even in the absence of elevated amyloid burden. So I want to switch gears slightly for a minute and talk about physical activity, since it's closely related to vascular risk. So in this study here, we wanted to test whether physical activity protects against amyloid-related cognitive decline and brain atrophy. And specifically, we were very interested in investigating whether the effects of physical activity on these outcomes operate through vascular risk pathways or independent of vascular risk. And then one novel feature of this study is that we investigated or examined physical activity objectively using a pedometer. So in this study at baseline, all participants were given a pedometer to wear on their waist for 7 consecutive days. And then our variable of interest was mean steps per day across that period. So prior to jumping into the longitudinal data, I first wanted to show the cross-sectional associations between physical activity with amyloid and the Framingham score. So as expected, we observed a significant relationship between physical activity and vascular risk, where higher levels of physical activity was associated with lower vascular risk. And then we found no association between physical activity and amyloid burden at baseline. So this suggests that physical activity is not impacting amyloid pathology directly. So now coming to the main results, we found a significant interaction between physical activity and amyloid burden on cognitive decline. So interestingly, this result held up after controlling for demographic covariates, ApoE4, but also the interaction of vascular risk with amyloid, suggesting that the effect of physical activity on cognition is not solely occurring through vascular pathways. So to visualize the interaction, here I've divided the sample into those who have lower physical activity, as well as those who have higher physical activity. And you can just see the mean steps per day in each of these two groups. And then I've plotted the effect of amyloid on cognitive decline. So lower amyloid in blue and higher amyloid in red. So I really want you to focus on this higher amyloid group depicted in red. So you can see that individuals who have higher amyloid burden and lower levels of physical activity show this very rapid rate of cognitive decline. However, here you can see that individuals with higher levels of amyloid who engage in physical activity at baseline decline considerably less steeply compared to their sedentary counterparts. And so this finding suggests that greater physical activity might attenuate the negative impact of amyloid burden on cognitive decline. And one really interesting aspect of this study is that in the models, the interaction of amyloid and vascular risk on cognitive decline was also significant. So this suggests that greater physical activity and lower vascular risk may have additive protective effects on amyloid-related cognitive decline. So now coming to brain atrophy. So we also found a significant interaction between physical activity and amyloid on total gray matter volume loss. And again, this was after controlling for demographic covariates, as well as the interaction between vascular risk with amyloid. So once again, suggesting that these effects are not occurring through vascular risk pathways. So as before, I'm presenting the results in terms of lower physical activity and higher physical activity. And again, focusing on this high amyloid group, you can see that individuals who have higher amyloid burden and who had lower levels of physical activity at baseline show substantial volume loss over time. However, individuals with a higher amyloid burden who engage in physical activity show much less atrophy over time. And in fact, these active amyloid positive individuals show a very similar trajectory as their amyloid negative counterparts. And then, like before in this model, we wanted to know whether the interaction of vascular risk with amyloid was also significant, and it was. So this again suggests that lower vascular risk and greater physical activity might have additive protective effects, but this time on volume loss. And so the next thing we wanted to do in this study was to examine whether specific regions were driving the effects in a previous analysis. And so we carried out an exploratory whole brain regional analysis to examine whether the interaction of baseline physical activity and amyloid burden on gray matter volume loss was driven by thinning in specific cortical regions. And so after adjusting for covariates and correcting for multiple comparisons, we found that individuals with elevated amyloid burden, greater engagement in physical activity was associated with preserved or slower cortical thinning in medial and lateral temporal regions, medial parietal regions, and also the insula. And so as many of you know, these are regions that are heavily implicated in episodic memory and Alzheimer's disease. And so I think these findings are really exciting because physical activity is something we all have the potential to engage in. I'll just make the last comment too before moving on that physical activity was just measured over a 7-day period, and it was solely based on mean steps per day. So I think we can, in future work, we can do a better job at gaining a better picture of one's level of physical activity. But I think these results are really encouraging. And in fact, we were very surprised by how robust the results were based on a very inexpensive pedometer. Okay, so up until now, I've been mainly focusing on vascular risk factors, but I want to switch gears and speak about cerebral amyloid angiopathy, or CAA. So CAA is a form of cerebrovascular pathology that results from the buildup of amyloid in the small and medium-sized arteries of the cerebral cortex and leptomeninges. And vascular amyloid accumulation is known to weaken the blood vessel wall. It leads to infarcts, ischemia, and also cerebral hemorrhages. And although amyloid plays a central role in both CAA and Alzheimer's disease, the two entities are actually considered clinically and pathologically distinct. So previous studies have shown that CAA increases the risk of Alzheimer's disease dementia. And so Boyle and colleagues found that greater CAA severity, shown by these different colored lines, was associated with an increased odds of Alzheimer's disease dementia. And this was after adjusting for things like plaques, tangles, and other common age-related neuropathologies. And so in this next study, we wanted to see whether, like vascular risk, CAA also interacts with amyloid to promote tau burden and cognitive decline. So this study was carried out in collaboration with the very talented researchers you see here as part of last year's Advanced Psychometric Methods workshop. So unfortunately, last year it was held by Zoom. It wasn't in person. So we spent a lot of time hanging out and getting to know each other over Zoom. And to address our study question, we used clinical and autopsy data from Rush. And so this included the religious order study, the memory and aging project, and also the minority aging research study. So coming to the results, first we found a positive correlation between CAA severity and neuritic plaque burden, as you might expect. So on the x-axis here, I have CAA severity, which was classified as none, mild, moderate, or severe. And then on the y-axis is mean neuritic amyloid plaque burden as measured by silver staining. And it's interesting to note that there's actually this non-monotonic relationship between CAA severity and plaque burden. But in general, as CAA severity increases, so does amyloid burden. And very interestingly, we also found a positive correlation between CAA severity and tau burden, whereby increasing CAA severity was associated with greater tau burden. Now, we wanted to delve into this finding a little bit further, and so we stratified this by amyloid burden. And so what you can see is that the association really appeared to be driven by those with high amyloid plaque burden. So you can see that in those with low amyloid plaque burden, there's almost no relationship between CAA and tau burden. But in the people with high amyloid burden, you can see that there's really this nice positive correlation. And so this really hints at an interaction between CAA, amyloid on tau burden. And so this is what we formally tested. And when we formally tested the interaction, we found that it was significant in a linear regression model. So here I'm showing you the model output. And you can see that the association between amyloid here and tau, so you can see that the association between amyloid and tau is much stronger at higher levels of CAA, so greater CAA severity. And there really appears to be this very nice dose-dependent association. And so these findings suggest that in the setting of elevated parenchymal amyloid burden, CAA might accelerate tau accumulation. So now moving on to cognition, as you might expect, we also observed a significant interaction between CAA and neuritic plaque burden on cognitive decline. So on the y-axis here is time in years, and on the y-axis, I'm representing cognition as a global cognitive composite, and they're represented as Z-scores. And you can see each increasing level of CAA here. And so what you'll notice is that the groups with the steepest cognitive decline were really those who had moderate or severe levels of CAA and also elevated levels of amyloid. So I showed you that CAA and amyloid interact to promote tau and cognitive decline. And so the next thing we wanted to do was to examine whether tau mediates the interactive effect of CAA and amyloid on cognitive decline. So is tau really the drive? Is the tau that's related to the interaction really the driver of cognitive impairment? And so like before, we ran two mediation analyses. So one in cases with high amyloid burden and another in cases with low amyloid burden. And what we found is that tau, in fact, did mediate the association between CAA and cognitive decline, but only in those who had high amyloid burden and not in those with low amyloid burden. So again, this is consistent with that interaction effect. And so this finding suggests that in the setting of elevated parenchymal amyloid burden, CAA increases tau burden, which then increases cognitive decline. And you can see that here through this indirect effect in the high amyloid group. Now, across both the high and the low neuritic plaque groups, we actually didn't find evidence of a direct effect of CAA on cognitive decline. So this effect wasn't significant. It was only significant when it was mediated through tau in the high amyloid group. And so this was somewhat surprising to us, given the large body of evidence suggesting that CAA triggers a host of vascular changes that are really known to impact cognition. However, when we thought more about this and also based on a comment from a reviewer, we're thinking that this could be because Rush enrolls individuals who don't have any known dementia at baseline and who are also on the older side, so about 80 years old on average at baseline. So it might be the case that people who have severe symptomatic CAA are underrepresented in the study. And it's probably because those who have severe symptomatic cases of CAA might not end up getting enrolled in this study because by the time that they're 80, they would have significant cognitive problems. And so we know that in severe symptomatic cases of CAA, brain lesions and things like lobar hemorrhages and microbleeds and superficial sclerosis might be more likely to impact cognition directly and even more so independently of tau. But to kind of summarize these results, they really suggest that when there is co-occurring parenchymal and vascular amyloid, that both pathologies could be targeted, and that might slow the progression of tau and cognitive decline at an even faster rate than by only targeting one. So hopefully today I convinced you that vascular burden and amyloid pathology interact to drive cognitive impairment through Alzheimer's pathways. So I showed you evidence that this occurs through increased tau deposition and also brain tissue loss. However, there's also likely other processes at play. So perhaps things like inflammation and changes to the blood-brain barrier. And it will be really important to investigate these and other processes in future work. I also want to highlight that we found evidence that vascular burden impacts cognition directly through non-Alzheimer's pathways. And again, this is consistent with prior work and not entirely surprising. Now, the good news is that we know how to treat vascular risk factors. So we know how to treat high blood pressure, high cholesterol, obesity, diabetes, and we have effective strategies to help people quit smoking. So it's really the hope that aggressively managing these risk factors can actually slow amyloid-related tau accumulation, brain atrophy, and cognitive decline. And I think an open question in the literature is, when is the optimal time to intervene? And we don't know the answer to this question, but I would argue that it's never too early or too late to make lifestyle changes to optimize your vascular health. And this is what I always tell my patients. So hopefully I can send you home with some take-home messages, and I hope that I convinced you that vascular burden might speed up amyloid-related tau accumulation, brain atrophy, and cognitive decline, and that interventional approaches that target both physical activity and management of vascular risk factors might have additive beneficial effects on delaying neurodegeneration and also cognitive decline. But I think it's really important to keep in mind that the results I presented today are based on observational data, and were also carried out in participants who are generally well-educated, of relatively high socioeconomic status, and who primarily identify as white or Caucasian. And so in future work, it will be really important to formally test these lifestyle interventions in clinical trials, and also to include more diverse participants. So I wanted to spend the last few minutes just discussing some of the work we have on the go in Toronto. As Stephanie mentioned, I did my postdoc at Mass General, and I've been in Toronto for a few years now. So I'm currently based at Sunnybrook Hospital and also the University of Toronto. And I've highlighted Toronto on this map of Canada, so you can all see where we're located. And so one really unique aspect of Toronto is that it's one of the most diverse cities in the world. And Canada is one of the most diverse countries in the world. And yet risk factors for cognitive impairment have mostly been studied in white samples in North America. And I was actually very surprised to learn that there is a dearth of published studies on the prevalence of cognitive impairment in non-white racial ethnic groups in Canada. And this really stands in stark contrast to the United States, in which now many studies have shown higher rates of cognitive impairment among non-white groups. So we know that African Americans are twice as likely to have Alzheimer's disease or another form of dementia, and Hispanics are about 1.5 times more likely. But the reason for the higher rates of dementia among these racial ethnic groups in the US remain unclear, but they might relate to differences in risk factors and social patterns. And so we recently launched a new study to investigate risk and protective factors for cognitive impairment and brain health in a multi-ethnic cohort. So we're calling this study CAMERA. It stands for Canadian Multi-Ethnic Research on Aging Study. And the hope is that this study will provide a critical lens into dementia risk factors for cognitive impairment in understudied Canadian ethnic groups. So we're primarily focusing on individuals of East Asian and South Asian descent, since these are the largest ethnic groups in Canada. And we're enrolling adults between the ages of 55 and 85 who have no substantial cognitive impairment, which we've defined as a CDR score of 0.5 or less. And so we wanted to be somewhat lenient here, because I think what happens is, as many of you know, is that a lot of, when we have a strict clinically normal criterion, a lot of people from different cultural or ethnic backgrounds end up screen failing it and then don't end up getting included in these studies. So we were really keen to be a little bit loose in terms of this eligibility criterion. So participants in this study will be followed annually for 5 years and will undergo biannual MRI scans. We have annual blood draws. We're including a number of different sophisticated wearable devices, so devices that will track sleep pretty intensely. We're going to be looking at sleep apnea in great detail, looking at physical activity. We're also going to be looking at hearing, using an objective hearing test, given that this has been recently identified as a risk factor for dementia. We have a host of different questionnaires to get at various social and demographic and medical factors. And in terms of a cognitive battery, we have a pretty extensive cognitive battery. And this is something we really gave a lot of thought to, given that we're including people with different cultural backgrounds, as well as people who likely have English as a second language. So we do require that our participants have that they're somewhat fluent in English, but it doesn't have to be their primary language. And so we have included mostly nonverbal tests, and we've really pulled a lot from cognitive neuroscience to really try to get at some of those areas that accumulate pathology early on. We've also taken advantage of eye tracking technology and using participants' eyes to try to provide a window into cognitive functioning, again, taking the language component out of all of our tasks. So we are actively collecting data on this, on participants right now, and hopefully I can come back another time and speak about some of our preliminary results. So recent research suggests that about 40% of dementia cases might be attributable to modifiable lifestyle factors. And so this includes many of the risk factors I already spoke about. So things like hypertension, obesity, physical activity, and then also includes things like low education, depression, hearing loss, and air pollution. And as I mentioned previously, it's been suggested that disparities in risk factors might explain the higher rates of dementia in non-white groups. And so I really began to wonder, is the general public aware of the link between these lifestyle factors and the risk for dementia? And based on some published work in other countries, and then also anecdotal evidence from my own life, for whatever that's worth, I actually think that the public is largely unaware of many of the risk factors for dementia. And this is obviously problematic because awareness of dementia risk factors can encourage preventative health behaviors and potentially reduce the prevalence of dementia and associated healthcare costs. So we designed a study to find out, what do Canadians actually know about risk factors for dementia? And we're particularly interested in whether the level of knowledge differs across demographic groups. So racial ethnic groups, education levels, and income levels. So in the first part of the study, which is done online, we're collecting detailed demographic information. And then the second part of the study examines the knowledge, participants' knowledge of dementia risk factors. So I'll just briefly go over how we assess knowledge. So we have a list of risk factors. Many of them are real, but we also have some sham risk factors. So things like chickenpox, breast cancer, arthritis, so things that don't actually are not known to cause dementia. And we have those so participants don't just select every item as a risk factor. So the instructions are to select true if they think that the risk factor increases, or the factor increases the likelihood of dementia, to select false if they think the factor has no impact on the likelihood of developing dementia, and to select don't know if they're unsure. So we have about 1,000 participants who have completed the questionnaire so far. And I'm not actually going to show any data today because it's still, we're still analyzing that preliminary data. But actually we are learning, in fact, that many people are not aware of many of the major risk factors for dementia. So this was, even though this was in line with my hypothesis, I think I'm surprised at how little some people actually know. To date, most of our sample, about 80% or 90% of our sample is white and mostly female. So we're really trying to target some more diverse participants. And then one interesting aspect of the study is that not only are we studying what participants know, but we also wanted to educate participants. So at the end of completing the questionnaire, we actually tell people what the answers are and then provide them with this infographic, which they can download, so that we actually have the opportunity to make a difference and educate people about what risk factors for dementia are. And so with that, I just wanted to thank all my collaborators from the Harvard Aging Brain Study. I've only listed a few who were mainly involved in the data I presented today. My collaborators at Sunnybrook, and then also the collaborators who are involved in the CAA project. And I want to especially highlight Emma Nichols, who is a superstar PhD student who really led most of the data analysis. And I'm happy to take questions. So thank you for your attention.
Jenny, that was great. Thanks so much. That was really a tour of many studies that you've completed that lead to a really impressive story and impress the importance of these modifiable lifestyle factors, I think. So thank you for that. We do have some questions coming in, and I'll remind everyone, if you do have one, you can feel free to put it in the Q&A and we'll try to address it. Zara had one that I don't know if you can read it, otherwise I'm happy to read out loud.
Okay, I'm just pulling it up now. Okay, do you want to read it out loud maybe, so then I guess everybody knows?
Yeah, absolutely. So she's wondering what you think about the potential mechanisms by which vascular risks affect tau accumulation in the brain.
Yeah, such a great question. At this point, I can only speculate. I don't know. One thing that I've been thinking a lot about is just the impact on clearance and whether vascular factors impact the ability to clear amyloid from the brain. And if it in fact does, we would expect amyloid to accumulate, which might then drive tau. So I think that's one possibility. Also, vascular risk factors and vascular impact on the brain just might make the brain more vulnerable and toxic to amyloid and potentially drive tau in that way. It's a really great question, and I wish I knew the exact answer, but those are my thoughts for now.
Great. Another couple questions from someone on kind of the later studies that you presented were, how was cognition defined in that last study? I think it might be referring to the CAA study. Yeah. And were there any differences in cognitive profiles between those with CAA and those who had high levels of tau burden versus those with low levels?
Okay, so I'm going to answer the first part and then we might have to revisit that second part. So yeah, I apologize. I didn't go into detail about how cognition was assessed. So we used a global cognitive composite. So it included tests across the gamut of cognitive domains. So episodic memory, semantic memory, language, executive function, processing speed. The paper should be coming out in the next little bit. So hopefully you can see a list of the tests there, but it's the common, it's the standard global composite that's used in Rush. And then, sorry, can you repeat the?
Yeah, were there any differences in the cognitive profiles between those with CAA who had high levels of tau versus those with low levels?
Yeah, we didn't really specifically run that specific analysis. My guess is that that would be the case based on our data, but we didn't run that analysis. But I would anticipate that for sure would be the case.
And then kind of a last question, I think, on that same study was, did these individuals have more pronounced amnestic decline?
Good question. I don't know the answer to that, but I'm going to run the analysis and get back to you. We really focus on global cognition, and we didn't look by domain, but it's a good question and we could.
Great. If anyone else has a question that they want to pop in the chat, we have just a couple more minutes left. Something that maybe was thinking about during your talk was the fact that physical activity and CVD risks seem to have, in some certain situations, independent effects. And I really think about, if you say vascular risk can be modified through therapy, I think of exercise as one of those modifications. So thinking of other ways to modify it, but also then I wonder if physical activity is measured by pedometer, could be measuring something else unexpected, like socialization or, just how much they're getting up and walking around and probably interacting with people. Have you tried to control then for some of these other factors to piece that apart?
Yes, I fully agree. Like maybe that pedometer is picking up like some aspect of general health, or, how often do you leave your house during the day, something like that. So I think it's a good point. And so, yeah, that's what we're trying to get at in this new study that we've launched. So we have more physical activity questionnaires, social questionnaires, actigraphy to be able to monitor physical activity a little bit more closely. Yeah, I think it's a really good point.
And one other question that came in here, perhaps the last one we'll get to, Gretchen says, great talk. And based on these studies and your experience, what's your sense of the best way to measure physical activity in this population?
Oh my God. I don't know. I think like the best we can do is actigraphy. I know like people look at VO2 max. I think there's pros and cons to every measure of assessment that's not overly intrusive to participants. So I think if you can also get good diary data to back up your objective data, that can often help. I think at this point, there's no perfect measure. But if Gretchen knows of one, I'd be happy to hear her thoughts.
Yeah, it's tricky. And hopefully with the advances in wearable technology, things will just be getting better and better, and implementation in hospitals and stuff like that. Okay, I think we only have a minute left, so we might want to wrap things up here. I think if people have questions for you, they could send an email, or if they have anything else.
Yeah, just thanks, Yakel, for the invitation. It was such a pleasure to speak today. And yeah, thank you to everyone for your questions and for listening. And feel free to shoot me an email if you have any further questions, or find me on Twitter, or you can get my email from Yakel.
Thank you so much, Jenny. It was great. Thank you also, Stephanie, for.
Yeah, thank you, Stephanie. So nice to see you.